Good afternoon to all of you. Welcome to a very special Wednesday afternoon lecture, the Astute Clinician Lecture. And we are fortunate this afternoon to hear from one of our own, Emily Chu, the Deputy Clinical Director of the National Eye Institute. It feels a little weird to have this lecture in Lipset because for all the 10 years that I've been NIH Director, these have generally been happening in Missouri, but as you may have heard, Missouri is under construction at the moment, and so until March, we will be meeting here instead, but it makes it cozy. Again, I want to say welcome to all the people listening by video, because in general, there's a lot more of you that I can't see than that I can see, and I'm glad you're all out there as well, because I think we are going to have a very interesting set of ideas and presentations put forward by Dr. Chu this afternoon. Just to run quickly through her academic credentials, they are substantial. She is one of those people who enrolled in a program which took you in 6 years from high school graduation to MD. She did that at the University of British Columbia for a year and then to the University of Toronto. But so in those 6-year period, an awful lot must have gotten packed into that time. Finishing her MD, she then did an internship in internal medicine and then a residency in ophthalmology, again at the University of Toronto, and then some fellowships in medical retinal science and genetics at Hopkins and in the Netherlands. Returning to Toronto in the Department of Ophthalmology as an assistant professor, she worked there for 3 years, and then back in 1987, we were fortunate to lure her here to NIH, initially as a visiting scientist in NEI, and then over the course of years, rocketing up through various positions of increasing responsibility into her current role as Deputy Clinical Director, Chief of the Clinical Trials Branch, and Director of the Division of Epidemiology and Clinical Applications. Her work has been recognized by a number of important awards. I'll mention particularly that she has received awards from the NIH Director for mentoring, something that she has obviously paid a lot of attention to and has made a real priority. She's also won the Helen Keller Prize in Vision Research in 2014. She won a Lifetime Achievement Award and the Jackson Memorial Lecture from the American Academy of Ophthalmology. She was also president of the Association for Research on Vision and Ophthalmology, ARVO, and received their Distinguished Service Award. So you can tell by all of that this is a true leader in the field of ophthalmology research. Her current research includes particularly focused on clinical trials and epidemiological studies in retinovascular diseases, particularly age-related macular degeneration, but also diabetic retinopathy and other ocular diseases, including some rare diseases. She is, in fact, interested and involved in an awful lot of interesting areas in ophthalmology. She was a co-second author in one of the papers that I think was most seminal in the early days of genome-wide association studies, that is the identification of a variant in complement factor H that's associated with age-related macular degeneration. That paper in Science electrified people who were really hoping that this method would work, and that was the first true success. But now she spends a lot of her time as the chair of various large-scale epidemiological studies, and I think that's a lot of what she's going to talk to us about here today. The age-related eye disease study, AREDS, being a particularly famous example, and also now the follow-up on that, AREDS 2, and also chairing the ACCORD eye study about cardiovascular risk in diabetes. So I guess this is somebody who doesn't sleep, at least judging by the number of things she is currently juggling and has done so for some time. We're very proud to have her as part of our intramural program. Please join me in welcoming the Astute Clinician Lecture presenter, Dr. Emily Chu.
That was so generous. Thank you so much. Thank you. Thank you, Dr. Collins, for that very gracious introduction. I'm very honored and privileged to be the 2019 Astute Clinician Lecture. This is truly amazing because I joined a group of incredible intramural, extramural colleagues and friends who've done amazing work in this area. So I'm very honored to be part of this stellar group. I have no financial disclosures. The NEI does hold a royalty-bearing license that issued to Bausch & Lomb for the AREDS supplement, which I'll talk about. So as a young child growing up in an Chinese immigrant family in Vancouver Island in Canada, my mother would cook with these goji berries and say, this is good for your eyes. This is filled with lutein, of course. And on a really before the tough exam, my father would say, you need some brain food, let's have some fish. And he would cook fish just like this. So little would they know that decades later that their little girl would be talking about nutrition and ocular health. We are what we eat. And this is from my kitchen, actually. So I'm going to talk about the leading cause of blindness, which is age-related macular degeneration. It is leading cause in the United States. 2 million people actually have the disease, and 8 million people are at risk. And it ranks third in the global causes of visual impairment. And you can see that by 2040, 288 million people will be affected by this condition. The risk factors are aging, smoking, education, and I will focus on nutrition and genetics. We'll talk about the age-related eye disease study, which Dr. Collins talked about, both the clinical trial as well as the observational data. I will speak about the cognitive function testing, which we did within these patients with macular degeneration, and the role of genetics. You heard a little preview about the GWAS that we did just on a whim. We were so lucky. And also I'll end up with a deep learning, which is an incredible tool that we have, and I know NIH is very much moving forward on this. I'll give you a little taste of this as we go on. So macular degeneration is mostly based on pigmentary changes and this thing called Drusen. This sort of yellow spot that you see in this area here and all over in this large Drusen. So early AMD is a matter of having what you call medium-sized Drusen. Intermediate AMD are those with large Drusen. And if you have a late disease, which is a vision-threatening part, the neovascular AMD or wet form, or the central geographic atrophy, for which there's no effective therapy. And you can also have geographic atrophy elsewhere, not involving the center. This is a patient of mine that I follow for 20 years here at NEI. I just want to show you the progression of macular degeneration. It starts with Drusen, they grow, they get large, you get pigmentary changes, and then they disappear. When they disappear, they cause havoc. You see the geographic atrophy. In the center part, that dark pigment is the fovea, the center of the eye, which is preserved. The patient still has 20/20 vision, but the central part, the pericentral part, has disappeared. The patient has terrible, terrible dysfunction from this. And if we see from the patient's perspective, patient may have very good vision in those with large Drusen. If I can just get this going. So they may have very good vision just like this for 20/20 for some time. But as time goes on, you're going to see an area of scotoma, which is usually central, and then they're robbed of their sight. Let me see if I can get this to go a little bit better. Here we go. And so you end up with a patient with a central scotoma and peripheral vision that's quite blurry. And very little is ever talked about, and this is the Charles Bonnet syndrome, or visual hallucinations that patients may have. Almost 15% of our patients actually experience this. We just asked them in our follow-up study. And this is a very unusual form in which patients actually see patterns to begin with. They actually see flowers. They know it's not there, but these are hallucinations that they realize are not real, but they have it. But they're actually afraid to tell you because they think they're going mad. And by the end, they might get faces, and also they may see buildings. And this is actually painted by a patient. These are perceptions of her visual hallucinations over time. So I'm going to give you a context of where the AMD treatment has gone. So give you an idea where we're going to talk about our AREDS supplement. You can see that in 1982, we had the laser treatments, which was really quite difficult to use, and patients eventually lost vision. And furthermore, there used to be called senile macular degeneration. You can imagine how patients felt about that, being called senile. And as the ophthalmologists got older, they decided senile was not a good name. They would call it age-related macular degeneration. And in 1999, the photodynamic therapy, which is a diverted porphyrin dye, which is photosensitive dye that you put into the body, and you actually treat it with a cold laser, and that was something that we had that held off treatment for a little bit. But really, the main thing has been the wet treatment with the intravitreal injections of the anti-VEGF therapy in 2006. In 2001 and 2012 is when we actually came on the scene with our AREDS supplement. So we'll talk more about the nutrition at this point now. The first clue that nutrition was important comes from the Nutritional Examination Survey, or NHANES survey, in 1988. It was quite clear that people who ate diets rich in fruits and vegetables, vitamin A and C, there was much less macular degeneration. In 1992, the National Eye Institute started the age-related eye disease study, mostly as a clinical, not as a clinical trial, but as a natural history study. But we decided we needed to do a clinical trial, and we followed patients for about 6 years, and then we had another 5 years of the clinical trial being stopped. It was just an epi study looking at the follow-up of these patients. And this was chaired by Dr. Rick Ferris and a really amazing team of 11 investigators throughout the U.S. We enrolled patients without AMD as well as those early, intermediate, and late AMD. We treated them, or we actually randomized them to a concoction of antioxidant vitamins, which was very popular at that time for cancer and for cardiovascular disease. Large doses of vitamin C, vitamin E, and beta-carotene, and zinc. And much to our surprise, we found the combination of vitamin and zinc resulting in a 25% reduction in progression of late AMD in 5 years. And this is what we see. As you see, it's a factorial design. The zinc and antioxidant was given singly, but together it was the best treatment, and it was 25% reduction. Interestingly, we followed patients for another 5 years without the clinical trial, yet we still saw a beneficial effect. Even at 10 years, we saw a 27% reduction 5 years after the clinical trial had actually stopped. So who should take this supplement? These are patients who have intermediate AMD, bilateral large drusen, or those with late AMD in one eye, but not for current smokers. Beta-carotene increased the risk of lung cancer in 2 NIH studies. And so for that reason, we were very concerned about the beta-carotene, and certainly not for people who are unaffected children of individuals. Quite often, the children come in and say, well, my dad has terrible disease, should I be taking this? And the answer is no, because it's only effective in patients with intermediate AMD. So it's really a secondary prevention and not for those who do not have the disease. But the public health significance is huge. Over 5 years, 300,000 people are estimated to be safe from having late AMD. In 2006, we started AREDS 2. Why did we do that? Well, because during the course of AREDS 1, we found that people who ate a lot of green leafy vegetables, the stuff that your mother told you should eat, spinach, kale, and collard greens, and also taking fish, the higher the intake of those, the lower the risk of having macular degeneration. And for those reasons, we actually added lutein zeaxanthine, omega-3 fatty acids, 1 gram, to the AREDS supplement. So we're adding these to see whether we have any effect on late AMD. AREDS 2 was different from AREDS 1. These were patients who already have AMD, so the majority of these patients have either late AMD or intermediate AMD, and that's another 4,000 patients in 82 sites. We then tried to eliminate the beta-carotene and lowering the dose of zinc as well, because that was concern to us because of the cancer issue. What did we find? The primary randomization showed that omega-3 fatty acids was neither beneficial nor harmful. The lutein zeaxanthine had an incremental increase in benefit. It reduced the progression to late AMD. And it was especially so in patients who did not eat greens. So the low dietary intake were people who actually ate 0 greens. There's a 25% reduction in development of late AMD with lutein zeaxanthine. And if you actually do a head-to-head comparison between lutein and beta-carotene, there's a 20% increase in the beneficial effect. So lutein always won out. The most important finding, actually, is the fact that there's a 2-fold increased risk of lung cancer in those assigned to beta-carotene versus lutein zeaxanthine. 90% of these were former smokers. So for safety reasons, we actually replaced the beta-carotene with lutein zeaxanthine to look like this. This is the AREDS 2 formulation. We did not add omega-3 because it was not beneficial. So this is the AREDS 2 formulation, which we recommend for our patients. Let's turn our attention to diet now. The Mediterranean diet, epidemiological studies have shown that in the Crete in Greece a number of years ago, cardiovascular disease was markedly reduced, probably associated with their Mediterranean diet. And this has been actually tested in a randomized trial. The Predictors trial was a randomized trial in Spain looking at patients randomized to a Mediterranean diet supplement with mixed nuts or extra virgin olive oil versus those on control low-fat diet. And this study showed that there was a 30% reduction in cardiovascular disease. So this is a very prevalent disease, so this amount of reduction is significant. The research question we have is, what is the association of Mediterranean diet with AMD? There have been previous studies looking at this. using our AREDS data, in fact. Dr. Murrow, along with Dr. Seddon, who is one of our investigators, looked at the longitudinal aspects of AREDS study as well as a European study called iRisk Consortium. What they found was that high Mediterranean diet adherence associated with less progression to late AMD by as much as 25 to 40%. So that's been established to a certain extent. So what is in the Mediterranean diet? We know they're low on red meat and refined sugars, high on fruits, vegetables, nuts, and legumes, moderate amount of fish, white meat, and dairy, and high on monounsaturated fatty acids such as olive oil. In AREDS 1 and AREDS 2, we had the ability to actually look at nutrition at baseline. We had two separate questionnaires that were done. These were self-reports for the past year. In the Gladys block, which is used by the NCI, and the Harvard Dietary Questionnaire. And for this, we looked at participants who had no baseline late AMD. And of those, there's almost 8,000 patients who were in the study. Excuse me. This is a combined AREDS 1 and AREDS 2 cohort. When we looked at the progression to late AMD, either the wet or dry form, you can see that this forest plot shows that it's all to the left. It's protective in the green zone. And if you eat more, the higher you are, the more protection you have. So there's almost like a dose response. For those of you who like numbers, this is what it looks like. These are the hazard ratios. So there's a reduction of about almost 29% to geographic atrophy. So the higher intake of Mediterranean diet was associated with decreased risk of progression to late AMD for both the neovascular and the geographic atrophy. And we looked for the 9 components. Which one was it? Well, it turns out to be fish. Fish is really important. And we found that the hazard ratio is 0.69. That's like a 31% reduction in the risk of progression, especially to geographic atrophy. And even if you look at patients who didn't have large Drusen, that's the intermediate stage of AMD. These are early cases, people without AMD. You can see that there's a protective effect of 25% reduction in the risk of developing large Drusen. So even at the early end of the stage, the diet was important. So this is a summary of what we found with the cohort that's combined versus the AREDS 1 itself and AREDS 2. You can see that the Mediterranean diet was important, especially for geographic atrophy. And this we applied what we call a Bonferroni correction to this. If you do a number of tests, you have to correct for that. It's like putting your hands in the cookie jar 100 times. You have to slap a certain rule on that. So that makes your p-value a little higher. So in this case, you see that geographic atrophy is really important in terms of Mediterranean diet in particular. Neovascular, not so much, especially in AREDS 1 and AREDS 2, but still it was in the same direction of being protective. And if we look at fish itself, and geographic atrophy in particular is important, and you see that this is highly significant for AMD. So the decrease in progression of late AMD in those with intermediate AMD was actually seen in Mediterranean diet association. Even going from early AMD to large Drusen, there was an association seen. So it appears to be important in both early and late AMD. So it may be never too late to start a Mediterranean diet. And associations, of course, that's not a result of clinical trial, but these are very compelling data. Now, let's turn to cognitive function. We did some testing in AREDS 2. This was done because we were interested in omega-3. Omega-3 was a randomized drug. We were really interested in seeing whether it had any effect on cognitive function. We know that this is a huge epidemic. It's 46 million people wide that are affected right now, and 5.2 in the U.S. It's going to triple in the next 4 decades to 131.5 million by 2050. And our hypothesis is, can omega-3 long-chain polyunsaturated fatty acids have any treatment on cognitive impairment? And we know the consumption of fish has been reported to have a decreased progression of impairment. So we did a cognitive function testing by telephone. We first tested their hearing to make sure they could hear well, and look for a test of depression because that also affects your cognitive function. And then we did a battery test, which are validated tests are done for a number of studies. We looked at the what's so-called TICS, the mini-mental state, which is by the telephone, very similar to what we call the mini-mental, and then looked at immediate and delayed recall, category of fluency, backwards counting tasks, and these were done at baseline and every 2 years by certified examiners. So this was a big undertaking. We were very fortunate. We had a number of institutes who gave us actually quite a bit of resources to do this study over the course of the study. So our primary outcome was looking at the effect of omega-3 on nutrition. We're also looking at other nutritional factors as well. We want to look at the change in the global score, the composite score, as well as the change in the tics that we talked about, and we adjusted for things that are important for cognitive function: age, sex, race, education level, and hypertension. We adjusted for all that. So you can see that in this randomized trial, the forest plot all includes 1. That means that there's no significant findings at all. So we found that omega-3 fish oil had no beneficial effect or harmful effect on cognition. We also looked at lutein, and again, you see the forest plots all include 1, so none of these were significant. No harmful or beneficial effect on cognition with lutein zeaxanthin. So we found, what about foods? The observational data suggests that eating fish may be actually very important, and rather supplements may not have an effect. So we went ahead and did analysis looking at the diet. So the AREDS study also had a cognition study done in 2000 to 2004. This was added to the protocol, and this is because at that time we had very high doses of zinc randomized to this trial. It turns out that zinc in the test tube can cause a lot of these tangles that are akin to Alzheimer's. So we're very concerned that we would actually have problems with our patients taking zinc. In fact, we found nothing. We did the similar sort of test, except it was done in person by similar certified interviewers, the exact battery test that I just told you. And so, of course, AREDS 2s, we have the longitudinal data, which we did not have in AREDS 1. And again, we looked at the data to see whether Mediterranean diet and the combination would have any effect. So we looked separately for AREDS because the data is somewhat different. You can see that, again, the higher the intake of tertile-3, the higher the intake of Mediterranean diet, the better the reduction in cognitive function, and the same with the composite score. So in other words, there's a significant reduction in eating good Mediterranean diet in this case. So a high adherence to the Mediterranean diet was associated with decreased cognitive impairment, and this is pretty significant, 63% reduction in tertile-3 with a mini-mental, which is considered to be a very important measure of cognitive function. In AREDS 2, we found similar findings. Again, the odds ratios are quite low in terms, again, 44% reduction in terms of the high adherence to Mediterranean diet was associated with a decreased cognitive impairment. And again, what happens with the component? Fish pops up again. It's a hazard ratio of 0.36, so that means there's a 64% decrease in the risk of cognitive function in those people who took the highest intake of fish. And that means 2 servings per week, and that's what it means to be high intake of fish. And again, in AREDS 2, we found a very similar hazard ratio. So this is very consistent that although the omega-3 supplementation did not work, we found that taking fish was important. So closer adherence to the Mediterranean diet was associated with lower risk of cognitive impairment. When we looked at fish, this was again to be important for the decreased risk of cognitive impairment. In fact, we looked for progression in AREDS 2. Mediterranean diet did not decrease the progression, but fish itself did. It actually improved the decreased incline. So it's very interesting that fish has such an important outcome. So let's turn attention to genetics. You heard a bit about this already from Dr. Collins. So we were approached by Dr. Josephine Ho, who was at Yale University, and she was going to do this Affymetrix chip that we didn't know much about. It had 100,000 SNPs in there. This was the first, my association in eyes. We thought, well, our sample size was going to be 200 per cases of neovascular AMD, 200 of geographic atrophy, and 200 of the actual of the controls. But she said, maybe we should just do a pilot. We'd go slow and not spend all our resources at once. So we just did 146 cases instead of 600. And lo and behold, we found that there was a 7-fold increased risk of late AMD with the presence of complement factor H, the homozygous. And what was even more important was the fact that 3 other groups actually published in the same journal with different methodology came to the same conclusion. And Dr. Hageman also came to the same conclusion he published later that year. So it's lovely that we have different methodology coming to, and this was a banner year for AMD genetics. And since then, and this was done by Dr. Zhenyu Tsai, showing that the complement factor H is in the eye, and this is done in a human eye. It's done here. So the NIH or the NEI supported a consortium, International AMD Consortium of 26 different studies, and we were part of that. We contributed our AREDS 1 and AREDS 2 data to this large consortium that had 16,000 patients and 17,000 controls. And we analyzed 12 million variants this time now. This is compared to the 100,000 that we did back in 2005. So things have really progressed over time. We now have 52 independent variants and 34 genetic loci, and chromosome 1, which is complement factor H, and the chromosome 10, ARMS 2, remain the most important SNPs in our armamentarium here. So the research questions we had is, what is the role of genetics on the AMD pathogenesis? Is there different pathways that are being used here? Are the AMD progression, is it affected by genetics? The dietary intake, such as the Mediterranean diet, is there any effect with interaction with genetics at all? So there are insights in the mechanism of disease. You can see that there are different pathways. These are some of the pathways from that paper that we did in 2016. So that gives us insight as to where this might be important and when we may be able to do some work in terms of treatment. It's also true that the different subtypes of AMD may have different genetic associations as well. ARMS 2 more so with the GA, the MMP9, CETP, and the TIMP3 is important for the neovascular form. So that hopefully will give us some clues as to the pathogenesis of this. So AMD is a complex genetic disease. Multiple genes are involved. As mentioned, chromosome 1 and ARMS 2 accounted for 60% of the hereditary. We also did an analysis looking at a genetic risk score using all 52 SNPs. And this was important to look at this. And these are my collaborators, Anand Swarup and Dr. Rinki Ratnapriya is very important in our own institution who helped us a great deal with this. We worked with the University of Michigan, Gonzalo Abacases, and Lars Fritz, and also a great investigator, Mike Klein, who's been interested in the genetics of AMD for many decades. And of course, our friends from the University of Pittsburgh were very important in this analysis. I'm just going to focus on one aspect of this and looking at the secondary goal of looking at prediction models using genetic effects on AMD progression. And we built 5 different models looking at baseline age, education, smoking, all risk factors for macular degeneration. We then added the genetic risk score. You can see that was pretty good with just the baseline education and smoking. So C-index is just like the area under the curve. The higher the number, the better the correlation. And you can see that adding the genetic risk score did help quite a bit. But if you just look at baseline severity AMD, just what does the fundus look like? Jumps up to 0.88, so that's a really important risk factor. If you add the previous risk factors, it jumps up 1 point, and when you add a genetic risk score, it doesn't really add very much. So we're very surprised by the fact that the most important prediction of this risk model is actually what you see in your eye. So getting an eye exam is really, really important. So overwhelmingly, the fundus findings were much more important. We were hoping that we would be able to use the genetics to help personalize our treatments. At this point, we're not quite there yet, but we'll be there sometime. So clearly, it's important to get an eye exam. Genetic testing is extremely important, especially for research, less so in clinical practice at this point. So let's look at the interaction of genetics and the Mediterranean diet. And this is now looking at the patients that I showed you earlier with AMD and the genetics. And you can see that these are p-values. None of them are significant. So there's no genetic interaction with Mediterranean diet in the combined AREDS and AREDS 2 population. However, if we look at the AREDS itself, we find one statistically significant finding, and that's for geographic atrophy and fish. And this, interestingly, the fish intake, again, comes up as being very important. So those patients with protective alleles of complement factor H had an increased beneficial effect on reducing development of geographic atrophy. So hopefully this will give us some more insight into the mechanism of disease. Why is that so? So this is actually very interesting. The higher you have of the complement factor H with the protective effect, the more likely you have a beneficial effect from eating fish. So should genetic testing be done in AMD? It's available in 23andMe, and others have offered AMD evaluation. Certainly, I don't think it's important for dietary recommendations. We have not found it to be useful for anti-VEGF therapies. There have been some studies suggesting that's true, and certainly not for AREDS 2 supplements for AMD. We've proven that it's not important to do that. And also, we don't do it because there's no prospective study to support testing for prediction of progression or response to treatment for daily or dietary recommendations. And the genetic testing is not recommended by American Academy of Ophthalmology at this point. So we're hoping that we will be able to do further. Finally, the artificial intelligence part, I think, is very interesting. Deep learning is a part of machine learning, which is a subset of artificial intelligence. We're extremely lucky to have wonderful colleagues across campus. So we talked about mentoring. You know how as parents you make friends through your children. Well, this is what we did with Dr. Zhang Lu and myself. We had a wonderful medical student who came to us about 3 or 4 years ago who was interested in natural language processing. We worked together with him, and then we further found more collaborations. And through that relationship, we worked with another medical student, Shazia Darcy, who's now an ophthalmology resident at Wilmer, Hopkins Eye Institute, along with his team, Yifan and Jin Yu and Alexis. And we have excellent clinician scientists, Dr. Tiernan Keenan and our statistician Elvira Agron and Dr. Wai Wong, who is our tenure investigator, have combined together to put this work together on the deep learning. And because we have such great images from these 2 studies, it was a natural place for us to collaborate and understand some of these. Our main goals was to detect features of AMD, whether it be large drusen, reticular pseudodrusen, pigmentary changes of late AMD, neovascular geographic atrophy. And we want to classify AMD based on severity on a person level using both eyes. And this will help us predict progression of AMD. I'm not going to talk much more about the progression of AMD because that's a long lecture. We're going to just talk briefly about these 2 papers that we're talking about. The DeepSeeNet is an algorithm that Dr. Liu and his colleagues have put together, and this is used to assess features of AMD on color fundus photographs. As you know from Google, they've done a lot of work on this, and in fact, the AREDS has been downloaded and many people have used it. They can actually even estimate whether you're female or male based on the color photograph with deep learning. It's quite amazing, and how much you can look at in terms of cardiovascular risks, et cetera. So for us, we simply want to just detect macular degeneration and to classify them based on a simplified severity scale, which we developed from AREDS. And this is to look at prediction of risk of AMD. So for this, we developed this about 10 years ago, and this is being used by the clinicians, which is look mostly at the evidence of large drusen or pigmentary changes in the retina, and we just count in both eyes whether they're present or not. In presence would be yes, and if you go up to 4, that means they're more severe. If you have advanced disease, then there'll be 5. That means that there's late disease in this case. So this is important because with each increasing risk factor, there's an increasing risk of progression in 5 years. If you have a risk score of 4 or have advanced disease in one eye, your risk of developing AMD in 5 years is 50% for that eye or for those 2 eyes. And if it's only 3 risk factors, it's only halving of that, 25%. And if you have only 2 factors, only 12%. If you have 0 factors, it's like 0.5% in 5 years of developing late AMD. So this is a very useful scale that the clinicians use. So we want to test this in our deep learning. So we developed this by looking at color photographs in both eyes. There are 3 neural networks. The one in the, here we have the, whoops, sorry. Here we go. We have the one for Drusen. We can measure whether it's small, medium, or large. We have one for pigmentary change, whether it's present or absent. And the presence or absence of advanced or late AMD. And this all goes into our algorithm, and we can come up with a simplified score, 0, 1, 2, 3, 4, 5. And this we have already curated in our data set, and we know what these are. We actually trained on 58,000 images of 4,549 AREDS participants, and we tested on 900 images, 900 participants with images. Our main outcome was to look for accuracy, specificity, and sensitivity as well. And the gold standards were the reading center. The reading center, this is read by a human grader who then was, actually there was 2 graders, and there was consensus built on these. We spent millions of dollars doing this for part of the study, and we wanted performance to see what this looked like when we compared to our deep learning. And we also compared to our 88 retinal specialists. So you can see here, the deep learning is on the left, and retinal specialists is on the right. We look for a drusen pigmentary change. All those numbers that are bolded are ones that are definitely more significant than the ones that are not. You can see that, by and large, that the deep learning did better in detecting and noting the size of the drusen as well as the pigmentary change. But for the late AMD, this was not true. And in fact, the retinal specialists did better than the deep learning. We believe this may be partly because we didn't have a lot of late AMDs in our training set. We train it furthermore with other data sets that will probably help us improve this situation. So, but overall performance for this simple scale was by far much better in the DeepSeeNet, the deep learning, than it was for the retinal specialist. So clearly, we do better. And as I'm now recruiting for another study, I understand it's very difficult for the ophthalmologist to actually understand what the size of the drusen is. It's actually a very difficult scenario. So overall, deep learning was superior to retinal specialists. I want to speak on one particular lesion, which is not even familiar for a lot of the ophthalmologists. It's called reticular pseudodrusen. And it's very different from the usual drusen we see. The drusen that we see here, this is underneath what we call the retinal pigment epithelium. It's the artist's depiction of this green layer here. It's a pigmented layer. Typical drusen is underneath that area, but these new drusen, what we call subretinal drusen deposits or reticular pseudodrusen, is on top of the RPE. You can see it here on the actual pathology that we actually see this is on top of the RPE, and this is the reticular pseudodrusen instead of underneath the RPE. And this particular case, you see it very nicely on a fundus photograph, but this is very unusual. We usually do not see it very well on color photographs. So this patient has the typical large drusen. You should see it with the white arrow. The black arrow shows the reticular pseudodrusen. Well, what's the importance of this group? Well, what's important, Kathy Kukers, one of my colleagues, has elegantly looked at this and showed that these are very important risk factors for progression to late AMD, and also they're associated with poor dark adaptation. Functionally, they're very different. So it's very important for us to identify this particular lesion. In AREDS, and you can see this is the black and white photos of the red-free photographs, and on the left down here, or on the right down here, you can see this is the OCT, optical coherence tomography, showing a very fine each layer of the retina and showing this looks very typical. It's a sort of sawtooth appearance of the actual reticular drusen. There are very specific findings for this. So the AREDS 2 had both the fundus autofluorescence images, which are black and white, and color photographs taken at the same visit. The deep learning trained and developed models based on the black and white because that's the best way of detecting the reticular pseudodrusen. And then we use a powerful technique of label transfer to see if we can use that to actually identify these lesions on color photographs. This enables the training models of images that contain features that are not consistently discernible by human experts, such as the RPD. So I'm going to show you an example here. This is one of my favorite patients. I follow him for 27 years. He's an AREDS patient. He's 97 years old now. He still tells me he can drive here. He's 20/20, and he does drive here. He has pseudoreticular drusen. Can we see it? It's a very blonde fundus. You can't see it very well. He has very poor dark adaptation. He'll usually come during the day, so it's really okay. And you can see here with the black and white that you see the pseudoreticular drusen, but with our deep learning, we can actually identify these lesions on the color photographs, which I think is going to be very important for future research. And this is the case of the patient. So this AREDS participant identified as having reticular pseudodrusen on color photographs using this label transfer technique, I think spells very well for our future research. And models using the FAF and the models using the color photographs was superior to the 4 retinal specialists that we did looking at the RPD. So in other words, again, deep learning was superior to the retinal specialists. And I was one of them. They were much better than I was at this. So deep learning can clearly detect lesions that are not discernible by human experts. So where does this lead us? Abraham Verghese, who's an author, as you know, feels that the computer really needs a physician. We're not ready to give up everything. It will not replace the clinician, but will probably enhance our diagnostic skills, improve our clinical management. As a clinical researcher, my hope is for a more precise measurement for the improved efficiencies of our clinical trials, There's still a number of steps we have to implement before we can actually use it in the clinical care. It's still very important for research, but clearly deep learning is here, and it's very important for us to go on and do more work on this area. So by simulating human grading process, the DeepSeeNet demonstrated high accuracy in an automated assignment of individual patients with macular degeneration and their risk categories based on the AREDS simplified scale. And I think it's very important that we think about deep learning to assist and enhance our clinical decision-making, to detect and also predict prediction of developmental AMD in the future. So this is a summary of what I've presented to you. AREDS 2 formulation recommended for persons with intermediate AMD or late AMD in one eye, and not before that. Genetic testing is encouraged, especially for a research purpose, not for clinical care at this point. Deep learning maybe help us with more accurate and more efficient clinical practice, and certainly a great research tool, but certainly will not replace us. The importance of Mediterranean diet and fish for AMD and cognitive function may be beneficial for those, even with early AMD or even intermediate AMD, that they seem to be beneficial. Remember, we are what we eat. So what about the future? So there are translational research on AMD that's being done at NEI. And again, I wanted to plug the fact that the AREDS 2 continues to give. An AREDS 2 patient's blood was used to actually produce some induced pluripotent stem cell technology to develop some iPSC cells, in which Dr. Barty, one of our great investigators at NEI, is going to look at in vitro disease models in this, setting up high-throughput drug screens with the help of Dr. Henry Wiley, one of my colleagues, who was a great retinal surgeon, to develop cell-based therapy using RPE cells for our late stages of macular degeneration. Another important goal is to do a preventive therapy for AMD prior to the stage of intermediate AMD. Perhaps this will lead to an AREDS 3. We're not sure about that yet, but certainly there are signs that may be very important for us to look at primary prevention. And with that, I'd like to thank my AREDS investigators and AREDS 2 investigators, and especially the patients, the thousands of patients who have spent more than 10 years with us on this study. This is dedication. Our loss to follow-up was only 3%, so that is an amazing, amazing study. And to my NIH family, they are tremendous. I think their dedication to public service is amazing. These are great investigators. Dr. Paul Coates really helped us a lot with supporting our studies, as well as Josie Briggs. They both have retired, and Janine Smith Clayton has been extremely helpful in providing resources for our study, and of course all my colleagues are really important here. I'd like to acknowledge, of course, the NCBI, NLM folks, Dr. Liu and his group, as well as MS Corporation has helped us with our study, Dr. Rusen to help us with our genetics as well, and of course our clinical center, the coordinators, the photographers, the technicians, and members of our division have been tremendous in helping us. And of course to my family, who've given me such support and for putting up with me and my cooking. And finally, I'd like to thank all of you for attending.
Thanks for a wonderful romp through a lot of work and a lot of data and very interesting conclusions and lots of work yet to do. We have time for questions, and I would encourage those who have questions to use the microphones in the aisle so people listening by video can also hear. We can start right over here.
Well, congratulations, Emily, for
Thank
an
you.
outstanding work and a super presentation. So the question relates to the issues of the composition. As you have shown, the metal ions and your antioxidant diets, they evolved. So you eliminated some, you added some. And it is interesting that it affected both the neovascular AMD and also geographic atrophy. So I was wondering how this composition of several materials are affecting both the disease with different mechanisms for the disease.
So I didn't quite get into the geographic atrophy and neovascular AMD. So the AREDS supplement, for example, which is vitamin C, E, beta-carotene in the past, but lutein now, seem to have more of an effect on neovascular. So it really seems to have stopped the neovascular more so than geographic atrophy. when we looked at the whole the data, and I didn't show you all the data for the diet, it seems to be more like the fish in particular is much more important for geographic atrophy. So the statistically significant findings mostly were for geographic atrophy, which is a disease which we have no treatment for. So it's very important to look at the mechanism and why complement factor H, the protective allele, would be so much better. So we don't really know, and obviously we're not going to be able to know for sure. We're doing these combination things. We are looking at nutrients. We're looking at the very long chain fatty acids. That may be very important, like the C28 to 34 rather than the C22, which is what we have for omega-3 fatty acids. So there's a number of things that we're looking at that might be important. We haven't, and there's increasing data from basic science labs. Nick Bazan from New Orleans has been talking to us about some of the things that he's been doing and looking at the very long chain fatty acids, and there's probably a whole host of other things. Mitochondria may be very important, which we know mitochondria is important in some of our pathways. So there's a number of things that we could try, and hopefully Koppel will help us, Koppel Barty, with his disease model, that we may actually go through a high throughput to look at some certain drugs and see whether that would be helpful as well. So there's a number of things we can add, but it's hard to know exactly what composition would be.
All right. After listening to you, I started taking lutein and zeaxanthin combination. I wish you could include chocolate, because this is what
Yeah, Emily, let me follow up a little bit on that, because I think we were all interested to see that while omega-3 didn't appear to provide benefit, there was this association with fish. So you're wondering, usually when people talk about benefits of fish, the light bulb goes on, oh, it must be omega-3. In this case, that doesn't seem to be the right answer. And of course, one does have to point out, at least I think I got this right, that the association with fish was an association. It was not in a randomized trial.
That's exactly right.
So one does then wonder what other confounders might be there, or the people who eat more fish doing something else that wasn't measured that was actually what provided the benefit. And I assume you looked at all kinds of other health behaviors try to see if there was anything else in there. Anything turn up? No, we didn't find anything. Obviously people who eat better are probably take better care of themselves. They probably take, their blood pressure measurement and blood pressure drugs a lot more than the others, and much more compliant. So they're probably somewhat different. Education obviously is very important. So we've looked at education and how much that contributes to it, and that's tied to your diet as well too. And education is a risk factor for macular degeneration. So you're absolutely right. There are confoundings. We're not saying this is it, but certainly there's very compelling reason to consider it. But we don't really know for sure, unless we do a randomized trial.
Just as an addition comment, lipofuscin dissolution has also been proposed as a treatment for this. I have the paper right here, incidentally, that I carry around in my book that I saw from a prior lecture on cellular senescence. I mentioned that as a treatment there probably in the future would be a treatment for some things, and lo and behold, it has been suggested. I'll show you the paper after. The other real question that I have is that you've suggested fish, but nowadays there's many varieties of fish, and there's fish farming. For example, I was looking at the benefits of tilapia. I don't know if that's Spanish or English, but they say it's fish farmed or you can get it wild. And the ones that's fish farmed doesn't have the same nutritional value as the farmed fish. So I think maybe it's something that's written within the Mediterranean diet, which I have never read, but perhaps you could be more specific on the type of fish that would be most beneficial.
That's a very good question. We really don't have good data on that because we did not ask specifically what type of fish. But it's always been thought that the cold water fish, such as salmon, sardines, that tend to be a better source of whatever the source that's important. But we really don't know for sure what that might be. And maybe further questionnaires might be able to iron out that a little bit better. We don't have that data, unfortunately.
Okay, thank you.
How about over here?
So along these lines, is it possible that fish protect not because they are fish, but because they come instead of something that is harmful?
Say that again.
Is it possible that fish protect not because they are fish, and especially that there's no correlation with omega-3, which is what we usually think about? So is it possible that fish protect not because they are fish, but because you haven't eaten red meat, which is actually harmful? So taking away detrimental influence as opposed to providing a positive influence.
That's a very good point, and people have thought about that, whether it's replacing something instead of that. We looked at it without red meat, and it still seemed to be beneficial. So
my second question would be, AREDS 2 is recommended in late AMD, but it doesn't seem to provide benefit in early AMD. Why?
that's, we don't know the mechanism of disease, and I think that's one thing Paul Sieving always said, you've got this drug, but you don't know how it works. But, we got laser that works, we don't know how it works either. So we don't know why that is. Clearly, I think is that there are two sort of pathways. Developing a Drusen for macular degeneration is one pathway. To get to the late disease is another pathway. So I think that's why the differences might be. And I didn't show some of the data that we've had. We've done some deep phenotyping of all our cases. And clearly, a complement factor H is highly associated with the formation of Drusen. ARMS 2 is related to the sort of neovascular and the more late stages and vision loss. So there's some different mechanisms in which the disease starts, and then somehow it goes to a certain stage, something else has to kick in. So that probably is the reason why some things work for one and not for the other.
Over here, Roland. Hi, great talk. A lot of people live in food deserts where they can't get fresh food. Is there any indication about canned fish versus fresh fish?
So apparently, when we look at that, we look at things like canned tuna, and that works just as well. So I think that probably is a good solution for people who can't get to the fresh food. I think that would be very important. That's a very important question.
Thank you.
And one more.
This question is about the omega-3 and fish. My understanding is that omega-3 is derived from the lipid present in the skin of the fish. And when you are eating fish, you have many other components. So is that the discrepancy?
So I'm sorry, I couldn't quite get the question. You said that there is...
Now, when omega-3 is derived from the lipid, it's a lipid. It's in the fish skin. Am I wrong?
Is it in the fish skin?
Skin, yeah. Or it is the component of the whole fish?
I imagine omega-3 is actually throughout the fish, not just in the skin itself. But I'm not a fish. I don't know that for sure. I go fishing, but I've never figured out whether the skin has only place. If you talk to my father, he always says, everything's in the skin. You got to eat all the skin. You got to eat the taro root skin. You got to eat the potato skin. You got to eat all the skin. So I don't know if that's really true, but
okay.
Yeah, I'm sorry I can't help you with that one.
Well, I want to say what an interesting presentation covering a lot of ground. We are going to have a little reception out here, which is going to serve fish with the skin on. And I hope you all will adjust your diet accordingly from now on, because you all want to see for a long time. Emily, I just want to say thank you for a wonderful presentation. Can we please give another thanks?